Had I known I was going to introduce this world-renowned speaker, teacher, mentor, humanitarian, I would have worn some shoes. But Gary just asked me to introduce him because he said he loves this guy so much he would get all choked up, and the truth is I feel the same way. I was trying to think of a story, something funny to start the lecture or something. And I can tell you, I met Terry when we were both young people. And in fact, about 32 years ago, we were driving to Mexicali, Mexico. In my old beat up, I bought a station wagon just so I could take it to Mexico. And in those days, we carry all our instruments, old clothes, shoes, to give it to the orphans. And Terry says, I'm really tired. I'm going to go back in the back there and take a nap. I said, okay, I'll drive. It's about 2.5 hours east of here. And he said, oh, by the way, when we get there, you're going to give a lecture. And I says, what? Oh, yeah. I'm too tired to give a lecture. And you speak Spanish better than I do. And I said, but what kind of lecture? He said, oh, don't worry about it. The minute you see the slides, you'll know what to say. And I said, no way, Jose. I said, at least give me the theme. I said, what are you talking about? And it was about crumb preps and packing cord. And it was basic restorative dentistry. And I said, oh, okay. So he goes back, takes a nap, and it takes us probably 2 hours to cross the border because we have slides, and the people wanted a mordida for us to cross the. Finally, we called the dean of the school, and he comes and gets us, and we go to the dental school, and we give a talk. And this is the most memorable one. And I think that's what kept Terry from wanting to go to Mexico anymore. They took us out to dinner, and it was carne en su jugo. It was a restaurant that served meat, the Mexican way. And the next 2 days, we were supposed to treat the orphans. Anyway, I kept asking, why is Terry in the bathroom? And I need to go to the bathroom. We only had one bathroom. We both got Montezuma revenge from eating dinner that night, the night before. Oh, I said, I don't think we're going to do this again. But the lecture was something, have you ever lectured without knowing or seen the slides before? That's terrifying. And you have to do it in Spanish. So anyway, I'm introducing my good friend who put me up to that. And I really feel for Gary because without any doubt, Terry has been the most influential friend and mentor for Gary and I. Basically, he guided us on our path, professional path. And when I met Terry, I was 28 years old, just got here to San Diego, and he took me under his wings. And the old motto about, Nike's motto about be like Mike, to me was be like Terry, that was the only thing I could think of. So I hope someday I can be as good as Terry, or even close to it. And he has mentored thousands of people through his study clubs, lecturing all over the world in anatomy, TMD, occlusion, restorative dentistry, professor at UCSD Medical School, been teaching at the PROS programs at USC. And one thing you guys don't know, but he was awarded the Humanitarian Award from Rotary International, an award that's given to 5 people out of 1.5 million. And after all the statistics we got, that's better than a Nobel Prize. And this is Terry Tanaka. So I said enough. Terry, my good friend, mentor, and big brother.
Thank you, Peter. Thank you so much. Oh, thank you so much. Hey, thank you very much for the kind words, Peter. And thank you, Gary. My gosh, I've got a slide about my feelings for both of these guys. And I'm humbled to be invited. I remember when you started this, Gary, I said, oh my gosh, you've got enough things on your plate. Now you're going to start this thing called TDO. I said, oh my gosh, and I had no idea. And so, and neither did Jan, right? But I'm humbled, and I'm really honored to be here. And it's really a pleasure to be here and to know Gary. Actually, when Gary came to town, he was a few blocks away before, and then very quickly moved probably almost across the street, probably three offices down from my office. And so we got together a lot, and I owe him a great deal. And I'm going to show you a couple of slides that I had two slides, and I decided to use both of them here. But I wanted to say thank you to Gary, and thank him for his your contribution to dentistry, to our studies, for everything you've done for me and all of our people that in anatomy. And many of the things that we've been doing, the slides that you're going to see today is because of Gary's insight and some of the gifts, major gifts that he's given us, microscopes and things like this, to enable us to do these kinds of things. And so it's with gratitude. Thank you. Thank you very, very much. So I not only thank you, I thank all of you for let's see, there's a few people here. Boy, these guys better be good dentists, because I had to put on shoes today and I wear a necktie today. And I found out you turkeys aren't even wearing a necktie, are you, out there? Okay. So what I thought I'd do is start out, and you're an endodontist, a couple of great GPs. Peter's probably the best GP prosthodontist in town. And he's done some work on me, actually, too, and my daughter. I'll just give you a quick CV. I'm one of probably 9 dentists in our family now. I have, my son is a dentist, my daughter's a dentist. I have 3 brother-in-laws that are dentists, and my son married a dentist. And there's a couple of surgeons in the family too, head and neck surgeons and a neurologist. So you can imagine what the conversation is like on New Year's. Everyone gets together, and everyone who's not in the medical or dental field usually can't understand the conversation, usually. But I want to thank you all, and it's been a fun ride at USC. It's probably, don't tell the dean, but it's probably going to be my last year. I went into it for the money, and was I surprised? No, I get the princely sum of $100 a month. I got a raise last year because they weren't paying me enough to meet the minimum wage. So now they gave me a raise, and now I'm getting minimum wage too. But most of the part-time faculty, like Peter, donate the salary back to the school anyway, so it's not a big deal. So you saw the title, it's a huge title, but the course that I teach at USC is called, I only teach grad students, everyone in grad perio, endo, pros, and advanced operative now. So I have 25 or 24 grad students every year. They all take the same class because I want everyone to understand the nomenclature and the terminology from perio to endo. I want the pros resident to know who Tony Gargiulo was and things like this. And so I want them to know who I want the perio people to know who Gary Carr is, and we'll work that all the way down the line here. So all these topics are related. I feel that my job is to relate to all the specialists what they should know about occlusion, what they should know about orofacial pain, and it's basically a course in basic diagnosis and treatment planning. And so I'm going to cover a lot of topics, but I'm going to base this on the questions that you sent in. If you didn't send in the questions, I will probably address them anyway, because when I develop a program, I usually think about the audience, and then if I was an endodontist, what question would I want to know about occlusion and pain, tooth pain, and other types of pain that mimic tooth pain? And so this is what how I'm going to address the program today. So if you look at these slides, what you're going to see is that we've got a number of slides here where we're going to talk about muscle disorders, for example. We'll talk a little bit about disc disorders. We'll talk about joint remodeling, early arthritis, advanced arthritis, and remodeling, for example. And we'll talk about these cases like this in relationship to, are these people going to have pain? This one will probably have pain. The one on the left, next to the one on the right over here. But the one over here, for example, with remodeling like this patient probably didn't have pain. My curiosity was piqued when I talked to Gary in regards to what was happening to these people that came in to see me in my office, in my clinical practice. Many of these people had different types of pain disorders. Now, way back in the old days, as you might say, we believed that occlusion in the slide from centric relation to maximum intercuspal position was causing all this pain. And people like Charlie Stewart, Peter K. Thomas, Harvey Stollard from San Diego, for example, were the proponents of this field called nathology. So I did 2 years of supposedly PROS training in the Navy here, which I didn't feel I had adequate training, so I did another 7 years of preceptorship with Dr. Peter K. Thomas in Los Angeles afterward. So I had a good grounding in occlusion and how to do occlusal adjustments and things like this. The problem was when I got out, and I was thinking as I went along, I started realizing that, a number of these people got better even without the occlusal adjustment. And many times, even without treatment, if they just got rid of some of their stress, they got better. If they exercised, they got better. And so we did a number of studies at UCSD. And so I was asked to start a pain clinic here at UCSD in San Diego. And I ran that one for about 15 years and for another 20 years up at USC, a facial pain clinic there. My entire clinical practice is probably 95% of my practice has been treating patients who no one else wanted to treat. Sounds like Gary Carr's practice, but we enjoyed the tough ones. We thought it was the tough ones, but things have begun to make sense in recent years, probably the last 15 to 20 years, and so the people that I saw initially for occlusal adjustment to fix their facial pain problems and their jaw muscle problems really didn't need as much of that occlusal equilibration. So the entire concepts of occlusion have kind of almost done a 180-degree turn. And so I'm going to share some of these thoughts with you. Many of the things we used to believe in the past, like grinding balancing side contacts, we almost never grind balancing side contacts anymore. Balancing side contacts, for example, exist because you don't have canine guidance on the opposite side, on the working side. If you had proper canine guidance on the opposite side, the working side, you wouldn't have a balancing contact. So further studies were done, and we determined, and others determined too, that the incidence of muscle and joint problems in patients with balancing contacts and without balancing contacts, but there's no difference. We also found out that where they told us that there was more force on the balancing side and that's why it was doing the damage to that joint, that was false too. Tom Corioth and others showed us that that wasn't true either. In fact, as a matter of fact, the force is less on the balancing side. So the neat part about teaching in a graduate program is we have to keep up with the literature. I know Jason Pham is here, and at least I hope he is, but I told him, you probably don't have to come back tomorrow, Jason, because you probably heard the same thing already. But I'm happy to see that a number of the residents are here also. And I'm extremely proud of them too. And so we'll take a look at these, and when this remodels then, when the condyle remodels, we lose condyle height. When you lose condyle height, what happens? If the condyle loses height faster than the teeth can intrude in the posterior, you end up with an anterior open bite. So the conclusion very quickly we found out was that anytime you see an anterior open bite that looks like this with tooth wear, your first thing you should do is get some joint films. And whoever thought of taking joint film for someone with an open bite? Everyone's looking at the treatment of this patient, for example. Or how are we going to fix the teeth? No, we got to look at the joints first. And so now the joints and the occlusion are tied together. As you start hitting on the posterior teeth only, all of a sudden you're looking at occlusal traumatism. And so we have hyperocclusion on these teeth. These teeth become very sore. And if they don't intrude fast enough, or if they're ankylosed anywhere in the PDL, those teeth aren't going to intrude. So we still don't know today why some teeth wear, why some teeth fracture, and why some teeth will intrude, and why some teeth will develop a widened PDL. Isn't that interesting in 2015 still? How do we treat these patients? We used to grind the teeth. We used to do occlusal adjustments. And so we'd use, get in and grind the teeth. But the problem was, there's a fellow called Vic Lucia from New York that developed an occlusal splint. It was an anterior jig. And he was getting really good results with these without doing an occlusal adjustment. And so we started looking at these different types of splints that were developed. We'll talk a little bit about these today. But we like to use these before we do any type of major work, or even advanced procedures, if you can get your GP to make a splint for these people, or maybe you might even be able to make one for your patients, because you can just make get a little vacuum form machine and make one of these suck downs. I'm going to march through this material because I'd like to show you some of the new things that we found in our anatomy dissections. We found that we've already known for many years that there's a lingual inclination of the mandible in the molar region. It's about 14 to 18 degrees. What that means then, though, is that the teeth aren't necessarily inclined lingually. We see the teeth are almost like this, almost vertical. What that means then, that brings the lingual root out to the lingual surface. So if the mandible's here like this, but the tooth is like this, it brings the lingual root out. And so what happens then, sometimes the lingual root is poking out of the bone itself. And so what happens is, if anything happens, for example, and you end up extracting the tooth, you've got a hole in that tooth. If everything follows suit, you put an implant in, you put your pilot drill down, first thing you're going to do is go straight through if you have to stay more buccal. So the farther back you go, stay more buccal rather than lingual. And so what will happen is, if you go lingually, you go out the hole, the pilot hole will go right straight through where the hole was already. The problem here is that the lingual artery is there. The lingual artery is there. There's a reason why they call it Big Red, okay? Because what has happened is, you can bag the nerve in the artery in the back, causing the bleed, or you can bag the nerve towards the front. Even the premolar, I'll show you a couple of premolars that are leaned lingually, and what has happened is that the apex of the root is sticking out. And the lingual artery hugs that as it comes around, enters the genial tubercle in the anterior. We'll show this towards the end, but I'll march along, and I believe we can get to that too. Other things that I'll mention just briefly, in case we run out of time, is that we find a large number of your maxillary molar roots in the maxillary sinus. People who place implants get really excited about the sinus membrane, the Schneiderian membrane, for example. They get all excited about tearing it or cutting it. And yet for years, head and neck surgeons have seen patients in the emergency room, for example, with the maxillary jaw fractures, Lefort fractures. And we look inside with them, and you see that the sinus membrane just torn up and everything. And they just irrigate it out and they push everything back together. I said, well, what about the sinus membrane? Oh, it'll heal, don't worry about it. And so I'll show you a number of things, because the same thing happens in the maxilla. If that root is already sticking out into the maxillary sinus, the only thing covering it is the sinus membrane. So it stands to reason that if you have sinus congestion and you have bacteria in the sinus floor, for example, it's going to settle right there and sitting on top of the nerve that's poking out of the like this, poking right out of the floor of the sinus. And so things like this, I'll show you some of these things because if you do molar endo, for example, probably you're poking holes in that sinus membrane almost, I would say probably 90% of the time. The only way you won't poke a hole in that sinus membrane is if you're short. Okay, so let's take a look. I'm going to pass on the taxonomy a little bit. I just wanted to show you here that when we teach at school, what we're teaching them is knowledge down below here, okay? And this is one of the lower order thinking skills. And our job at school is to teach the individuals, teach the doctors how to think. And this is what we want to do. And yet, as far as knowledge is concerned, but the advantage of coming today, and I enjoy a group like this, is because you've got experience and the knowledge. And this is what's neat, to come to a group like this. So as far as the diagnosis is concerned, that my friends are talking about at school, that I emphasize in my program, I have a short part that I call When Two People Meet. And I emphasize to them, please pay attention, pay attention. Don't be thinking about picking up your clothes at the cleaners on the way home or filling your car up with gas and things like this. If the patient's sitting in a chair, they deserve your 100% attention. And so I admonish them to pay attention and listen to the patient. Listen to the patient first. You like the one by Yogi Berra, who passed away just recently this past week. Allow them to tell you their story. Allow them to tell you their story. Okay? And so don't butt in for the patient. Don't butt in, be patient. Observe the patient very carefully. Because the facial signs and symptoms, the physical signs and symptoms will tell you many times what the diagnosis is if you just take the time to be patient and watch them carefully. The words they use to describe their problem are actually telling you what the diagnosis is. But you have to be able to listen, okay? Let me give you a quick example. I've had this achy sore jaw ever since I knew this new crown was made. And that's musculoskeletal pain. I get this throbbing headache when I get sick and throw up. That's migraine, isn't it? It's vascular. I get this sharp shooting pain. That's trigeminal neuralgia. They're just telling you with simple adjectives what their problem is, yet they're giving you the diagnosis. And then these patients come in, they say, 11 dentists have already tried to adjust my bite, but I heard you're the best. Ooh, that's a kiss of death, isn't it? That has referred to Peter Shaw on it all over the place. All kidding aside, okay. So what we're going to be looking at here is this. We're going to be looking at what should dentists know about pain that affects the head, neck, and TMJs, for example. What should we know about the brain and its functions? What should we know about the oral cavity and respiratory function, tongue position? Where should epiglottis be? What is the function of these muscles here? What about the nervous system? And what about the psychological components? And what does that have to do with teeth? They're all related. And so that's what we're going to talk about today and how these are all related. So here's some of the questions that Gary, you all sent them in, Gary sent them out. A number of people asked about, could he talk about some of the occlusal schemes like anterior guidance, canine guidance? When do the guys use group function and things like this? What kind of occlusion should we have on crowns, and should they be different on implants? And why should you know about this? Why should endodontists know about this? I'll tell you why. Because the general dentist today is not adequately trained to answer these questions. And what you have the advantage of is you have 2 and 3 more years after you get out of dental school to sit down and ask people these questions. And you get the experience in dental school to address these problems before you get back out. Otherwise, we just graduate them. Hopefully, they're not dangerous still, And, then they're on their way. Some of them very rarely even do an adequate job with their CE. What about occlusal trauma? Okay, how about deprogramming muscles, for example? What about clicking and things like this? Is clicking important? Sure, it's important. When was the last time you saw a patient with a clicking joint that you checked the patient for a clicking joint? And if you didn't check the patient for a clicking joint, that you had the patient go through endodontic treatments, and the patient sued you because they had a joint problem afterward. Okay? I get these because people call me, they want me to come to court and testify for them, some of them my residents. And I'm too old for this, okay? And so I'll teach you some simple things you can do in 30 seconds that you can determine the joint is sound. And then from here on, you can go ahead and do all your work. We'll also go through some techniques for you that you'll find patients come in, you're scheduled for a second molar endo, and the patient can, you say, open please, and the patient opens 25 millimeters. And you say, oh, great, 25 millimeters. Well, the time they're scheduled for endo is not the time to make that decision. Initial examination is the time you should make that determination. But there are techniques to help you solve that problem too. Okay, we'll talk about use of ethyl chloride, for example. So you asked about non-carrier cervical lesions, sleep and airway sleep appliance, and some problems they're having with sleep appliances. Also, in regards to the neurovascular bundle, mental foramen, things like this. But we'll save some special time to access how you access the maxillary sinus through the ridge or Caldwell Luck. We'll talk about some of the precautions you should take making flaps and things like this. Okay. Some other questions were here. I'm going to address those, but on this side, for example, I'll basically talk about the anatomy of the maxilla and the mandible, and in doing so, it'll answer a number of the questions that you might have, and hopefully it'll keep you out of hot water. Okay. And so let's start with occlusion here. And just briefly, we won't start with it, but I'll just address this. This is one of the myths that existed for many years, that if the patient had a slide from this position, that was centric occlusion. They said this was centric occlusion relation, and this was centric occlusion, that there was a slide from CR to CO. Well, actually, there is not a slide from CR to CO. CR is the same as CO. The definition in the glossary of prosthodontic terms for centric occlusion is where the teeth fit together, the jaws fit together in the centric relation position. So centric occlusion is the same as centric relation. So there's no such thing as a slide from CR to CO. The slide is from CR to MIP, from the maximum intercuspation position. So what we're going to talk about then is, what I'd like to address at the start is, there's a classification for pain, and I can go through this very quickly, and we classify them in two categories. One, the physical problems, and the other, the mental problems, or the psychological problems. And so axis one are going to be the physical problems, are going to be vascular, neurogenic, musculoskeletal problems. And then the psychological problems will be the ones where the people have depression, anxiety, and a number of the other personality type disorders. Okay, or bipolar type disorders. And so we classify these as in the categories of axis one of chewing or masticatory muscle disorders, joint disorders, adhesions and problems in the joint, inflammation, and I'm only going to cover basically muscle disorders, joint disorders, and inflammatory disorders. We don't have time to go through too many of the growth and development type problems. I might show you one slide of a patient with a growth problem and facial asymmetry. Okay, this is a project that I developed way back in 1976, 77 through 79 actually. And then we developed a pain clinic team here at UCSD Medical School. And we've had some really, really nice people at the med school that cooperated and helped me out with these. Now, let me kind of explain how this works. Pain in the human body, I feel, can only come from three basic sources. The pain is either going to be vascular, neurogenic, or it's going to be musculoskeletal. And the fourth one might be psychological. But we're finding many of the psychological problems are actually some in the physical domain also, neuropathic pain. The interesting part is if you listen carefully to the patient, how the patient describes their problem, if you listen to the adjectives that they use to describe their problem, they are actually telling you what category this patient's problem is in. Let me give you a quick example. People with vascular problems will almost always describe the pain as throbbing, beating, pounding pain. It's a headache of throbbing, beating, pounding type pain. What's a typical throbbing, beating, pounding pain in dentistry? Pulpitis. Pulpitis. So you pick it up right away, okay? Now, the typical example of this is going to be migraines, classic migraine, common migraines. What about the treatment of these? How do we treat these? We treat them with usually Imitrix. It's not a standard over-the-counter medication. Splints don't work, okay? Even though you've read some papers about it, they're not treating true migraine. They're treating tension-type headache that precedes the migraine. That's what they're treating. Okay, so basically, if you look at this, what I'm going to do is I apologize. Old guys don't work too fast, and so I got this thing through. And what I'll do is I'll give you a handout, or you can just I'll send it to Gary. You can go to his website or go to mine, either one, and just take it off, and you'll have all the slides and everything like we do for the grad students. And you'll have both this and the second program that I'm going to show. And it'll be six slides on the page with all the slides and everything else. So I'm not going to take too much time to go through and read a slide, for example. As far as neurogenic pain, the second type is very simple. Listen carefully, and the patient will almost always describe the pain as sharp, stabbing, numbing, burning, tingling type pain. Best example, trigeminal neuralgia. Trigeminal neuralgia. It's a dead giveaway. There's trigger areas. You simply touch the area, or the wind blows, the fan blows across the face. It sets up a trigger. The patient jerks like this. How do they describe it? Sharp, stabbing, shooting type pain. Okay? So very quickly different from the first one. The third category is going to be neuromuscular or skeletal pain. Pain from muscles, tendons, ligaments, and joints are described as dull, achy, sore, tight. Dull, achy, sore, and tight. Typical examples are your typical TMDs, muscle disorders, joint disorders, and these types of problems. We treat these with over-the-counter drugs. So if you ask a patient, what do you take to get rid of your pain, to make this pain feel better? And they say, oh, I take Advil. Right away, you know it's not vascular, because that's specific to Imitrix. You know that it's not neurogenic, because that's more specific to what? Things like the neuroleptic drugs, Neurontin, gabapentin, and things like this. Okay? But if they say, oh, I take Advil, or I take Tylenol, then right away you know you have a very good idea. You can zero in on the diagnosis very quickly. The psychogenic part is the difficult one, because the description will vary between patients and between appointments and may be inconsistent. And the bad part of it, the patients are not aware that they're doing this, okay? And the diagnosis is not confirmable usually, okay? If it's not confirmable, please don't do any occlusal adjustments or anything reversible. So here's how this looks. The vascular disorders are typically classic migraine, common migraine. You know what these are. Someone gets a throbbing, beating, pounding headache. They get sick to the stomach. They got to lay down in a dark room. The Advil doesn't work. Over-the-counter stuff doesn't work. So right away, with that description, you know right away what this is. If any of you have a friend with migraine or relative, ask them, test this out. Just ask your relative what to describe the problem, and right away you're going to see this. Neurogenic disorders, on the other hand, are also interesting. Oh, I should say here, refer these patients to the neurologist. Don't try and be a hero and make a splint for these people and things like this. It's not going to work. Okay, neurogenic disorders, they're going to describe a sharp shooting, stabbing type pain, and they have a trigger area, for example. These medications don't work. Okay, standard Advil's not going to work, over-the-counter stuff. You can treat these patients with Neurontin or gabapentin, okay? Neurontin, 100 milligrams TID, for example, these people in 3 days, headaches, that pain is, trigeminal neuralgia pain is gone. Okay, but please, you may run one trial, but that's it, okay? Because if you're going to treat trigeminal neuralgia, for example, and use Neurontin, you've got to check whether this patient has glaucoma and high blood pressure and other types of significant tests. And if you don't, these people, you're setting yourself up for a nice suit later on. Now, you can make the diagnosis, refer them off to the primary physician, okay? So very quickly then, let me take you through the processing of pain here. We call this, when people have pain, any parts of the body, vascular, neurogenic, or musculoskeletal, what's going to happen is they're going to go through a certain perception or processing of pain. They're going to feel something here in the lower jaw, for example, and they may feel something like this in the lower jaw. Or what will happen is they may feel it in the shoulder like this. They may feel pain in the shoulder, but what happens is, even though the pain actually originates in the shoulder, the pain source or the origin of the pain is in the shoulder. They've been working in the garden too hard, and now the shoulder's sore. What happens is, watch this, the pain message goes from the pain source down to the brainstem here, goes up the lateral thalamic tract, goes up to the cortex. Only when it reaches the cortex do you feel the pain. It says, ouch. If it doesn't reach here, you're not going to feel the pain. So what happens then is, pain sometimes comes from here, the source, comes to the brainstem, and it takes what's called a second order neuron. It gets sidetracked, comes up this way, and comes out near the temporomandibular joint. The patient feels the pain in the temporomandibular joint, but the actual source of the pain is here. Then another thing, it can come up here, take not the second, it goes to the third order neuron, and now the patient feels it in the temporalis. So now the higher centers get messages from 2 and 3 different areas, and you get mixed signals. And what happens here then is, this is what's very difficult to diagnose. But there's a simple thing you could use in probably 15 to 30 seconds that will solve this problem for you. Here's what it looks like tooth-wise. Keep this in mind. Is anywhere in the body, your back, for example, it could be your finger, it could be your shoulder, or it could be a tooth. If you have pain in the tooth, if there's sustained pain, pain messages are sent repeatedly to the higher centers until they're felt up on top. If you feel it, it's already reached the cortex. Okay. If you have repeated messages to the brain that are felt at the higher levels, what happens is the cortex finally says, okay, I get it. You can stop sending me messages. I'll start the pain here and send it back to you. So this is what happens. You sensitize the higher centers. And what happens then is someone comes in with a toothache in the second molar. They come in with a toothache in the second molar, and you look at the tooth, and X-ray looks good, not sensitive to percuss. You kind of press on it, the patient says, oh God, when I press on it like this, it hurts. And yet you press on it, you tap on it a little bit. No, not really. Ice, heat, no. Vitality, no. And yet they say, it just bugs me. Finally, the dentist that referred says, will you just do the darn root canal for me and get her off my back? So, okay, you do the root canal, do the endo. She comes back 2 weeks later, says, it wasn't that tooth, it's the one next to it. You've heard this story before, okay? So what happens is, it's that one. No, it was the one in front of that. Oh, after the endo, it's the next one. You know better, okay? You should know better. But the GP doesn't always get this. And I do programs for dental societies and dental association. I'm going to the ADA next week at the end of the month. And I'll be surprised, I won't be surprised that easily probably 75% of them have never heard of this problem. What happens is you end up with an edentulous ridge. The problem is the patient comes to me or Peter, and then what he's looking for, what the patient is asking, that is saying that the analgesics and the NSAIDs are not working. Even narcotics won't stop the pain. Okay, so what does it tell you? If the medications are not working, it's got to be vascular or neurogenic. But listen to how the patient described the pain. That's your first tip. Okay, then what happens is you're really stuck with some of the neuroleptic drugs. What happens here is this. This patient now has had all these teeth removed, comes to me for a partial, and says, this area, just touch it and it hurts. It's still sensitive. She gets acute pain from that area. So what are we going to do at this time? So the moral of the story is this. I'm not going to make a partial for this patient. She can't wear a partial over this area. Okay, we got to get at this. I'm going to refer her to the medical school and their pain clinic and let them work this thing out. But in the meantime, my advice to you, if you get a patient who has tooth pain, undiagnosed tooth pain, and the tooth looks good, after you've considered relieving the occlusion on the tooth so it's no longer contacting, okay, I wouldn't do too much else. I wouldn't do too much else. In fact, I wouldn't even consider doing, if this is hyperocclusion, for example, and it's not, I'll show you how to use some mylar strips. Once you grind the tooth, now it might be an Emax or one of these real hard crowns, or if it's a natural tooth, now the dentist is mad at you, the referring dentist is mad at you because you ground his nice anatomy on his tooth, on his nice crown. Okay, so be careful of these patients. This is called atypical facial pain. It's we call it psychogenic pain. Here's a patient that was 3-year history of persistent pain. She'd like me to make her a partial, for example. She's seen 11 dentists. 2 of them were endodontists. But most of the root canal were done by the GP. And the diagnosis was central sensitization. You sensitize the higher centers. You keep bombarding it with these pain messages. Okay. So what are some of the pain problems that endodontists see most frequently? I just started this and got sidetracked, but you're going to see pain from pulpal. You can diagnose this better than I can. Hyperocclusion, be careful. We'll talk about this as we go along. A new crown is a dead giveaway. Macrotrauma. Somebody gets hit in the jaw, for example. Microtrauma from clenching and grinding. And sometimes an occlusion with patient with a constricted anterior envelope. This 5th patient is a class 2, division 2 with a deep bite. What we didn't teach you in dental school is, what we did teach you was this. Growth in the female continues till about age 15, 16 at the most. Growth in the male usually occurs until about 18, maybe 19, and up to 20, 23 in some of the Asians. Okay. But what we didn't teach you in dental school was that from 37 to 77, the face continues to grow. As the face continues to grow, the mandible, the condyle grows up and back into the fossa, causing the mandible to translate forward. But with the maxilla here, it's not allowed, it can't go any further. So what happens is, it's going to drive the lower incisors back. If the teeth are slightly crooked, this is where we get the crowding. Upper incisors come down. So this is where you hear people talking and they say, when people get older, you see less upper teeth, you see more lower teeth. This is exactly what Rolf Barentz and these people were talking about. Okay. As far as psychological patients, I just put this in about a half hour ago. I was thinking about this patient, and it was one of my patients in San Diego. He was with me for probably over a year. And he kept adjusting his own teeth, adjusting. He'd been to a number of people. He looked like this when I first saw him. And finally, interesting case. We ended up in another dentist's office, and the guy immediately, within 3 weeks, had done a full mouth reconstruction on him. He could just see $50,000 just like that. And what happened after this, though, was that the patient came back again to my office and wanted to see me again and needed more adjustment and things like this. But he was the guy that went out and bought wet and dry sandpaper. And he had been watching everyone do his adjustments. So he would cut it into a horseshoe, put it in his mouth, and did a chew-in over the weekend. And this is typical of some of the psychogenic problems. The dentist that did the full mouth reconstruction on him really should have stopped. And unfortunately, the guy died about 4 months later. Patients like this, you think they're psychogenic. You think they're psychogenic, but there's simple problems too. The patient had a whole bag full of dentures. This is the prosthodontist nightmare, where they come into you with a bag full of dentures and say, "Can you make me a denture?" Well, she was on all kinds of medications, and she had what we call dyskinesia, and she couldn't control her tongue and her jaw movements. It kept moving. So, what kind of teeth would you put on a denture for a patient keeps moving from side to side? Give her flat teeth. She was happy as a bug. And all it took was about $24 worth of teeth, new teeth. So there's some simple solution to some of these psychological problems too. So don't assume that the problem is psychogenic if you can't make the diagnosis, okay? I say this and I pause because for many years, and the medical profession is guilty of this too, and all of us talk about this every time at Christmas or New Year's when we get together. When physicians and dentists can't come up with a diagnosis, if you're not smart enough to make the diagnosis, we used to think these patients, if they didn't get better with an occlusal adjustment, we'd do another occlusal adjustment. If they didn't get better from that, we'd make them a splint. If they didn't get better with a splint, oh, it must be in your head. We're going to refer you to a psychiatrist. And then about 12 years ago, a whole new field opened up called neuropathic pain. Can you imagine all the guys who had egg on our face that used to call these guys crazy and Looney Tunes and everything else? And when you think about it, really, it was embarrassing because we called them names because we couldn't come up with a diagnosis. It's a learning thing for all of us. This patient pointed all over the place. And finally, I said, where does it really start? She said, oh, well, right here. And now she's pointing to the tooth. And Gary, did you see this patient? I think one of many. I think, yeah, it could be. This is about 20 years ago. Okay, so as far as myofascial pain and myalgia, we're going to talk in disorders, for example. We're going to go into this. This group of musculoskeletal pain, for example, they constitute 75 to 80% of all body pain. They constitute 75 to 80% of all headaches. We used to call these muscle contraction headaches. Now we call them TTH, or tension type headaches. So keep in mind, if the patient has joint pain, if they have muscle pain, the bite's probably going to be off. Okay? And so if they have muscle pain, the bite is probably going to be off. And I repeat that twice because this is really critically important. It's a transient type of malocclusion. Okay, if the muscles are sore, I can guarantee you the bite's going to be off. Okay? If the muscles are tight, that's not the time to do an occlusal adjustment. And so we have to think about some of these things. If you look at an x-ray, and you see an x-ray that looks like this, for example, if a patient has pain in the joint at rest, if a joint is painful at rest, it's probably an inflammatory response. It's more an arthritic type of thing. If it's a disc problem, at rest, the patient has no pain. If it's a disc problem, when the patient's at rest, sitting there calmly, they have no pain. There's no movement. There's no pressure on the capsule or anything. But any pressure or like this is a osteoarthritic patient, and that's the keep in mind the patients we used to see are almost all in the anatomy lab are all cadavers of probably average age 75 to 80 years of age. So what we see in the joint is not a true representation of what we see at the chair, but it's pretty close. Okay. Musculoskeletal pain, there are two types of basic arthritis you should know about. One is systemic arthritis, the other is a localized arthritis. Systemic arthritis is easily diagnosed differentiated from localized arthritis. For many years, I marveled at physicians who would walk in and there's this program called The New Medicine. And in it, it explains that the average physician now, a primary physician, has about 6.5 minutes to greet the patient, say hello, do the examination, make a diagnosis, write the prescription, is walking out the door in 6.5 minutes. Okay? How could they do this? Well, let me give you some tips, because you've been using them in the past, but let me give you some regarding arthritis. Two types, basically. There's some other things like gout and a bunch of some other minors that constitute probably 4% of all the arthritic disorders, but 96% are going to be in this category, okay? Systemic arthritis affects only the metacarpal wrist and the metacarpal bones and the thumb, okay? On usually both hands. And look at the slides. The one on top is systemic arthritis. So my exam starts, say hi. Before I even shake hands with the patient, I say, go like this, please. Go like this. Turn your hands over. Okay, right away. I have a pretty good idea whether there's systemic arthritis or not. Okay. Second thing, look at the fingers. How can you do this? Sure. Then gently go like this and feel the knuckles. Any sore joints? Yeah, I've got a little arthritis and so on. Okay. If it's sore, the last two joints here are called the DIP joints, distal interphalangeal joints. If the DIP joints are sore, it's osteoarthritis. 80% of the joint pain is going to be osteoarthritis. Okay? So the remaining probably 12 to 13% is going to be systemic arthritis or rheumatoid arthritis. But some of the others could affect the joint too. Okay, but the hands, just the simple, before you even do a handshake. Facial asymmetry. What do you think caused the facial asymmetry? Trauma on this patient. You look at a patient and see facial asymmetry and say, how long is, you notice your jaw's off to the side? Oh yeah. Well, it's because I fell off my bicycle when I was about 8 years old. And if you look carefully, that's the coronoid process here. That's the condyle right there. It was pulled forward by the lateral pterygoid. And he just simply grew another condyle up into the fossa. See this? He simply this is the coronoid process. Here's the old condyle. When it fractured, the lateral pterygoid pulled it forward, and the body just grew another condyle back here. And guess what? He probably just grew another lateral pterygoid. And so the body has many very nice, interesting means of repairing itself too. Okay, now this part is really, really interesting as far as the bite is concerned. Okay. Because you don't want to get into it with your referring dentist. I tell my endodontic residents, don't get into it with your referring dentist. Don't sour your relationship with them, but you got to be firm, because you don't want them to think you're the whipping boy and you're going to do all their occlusal adjustments for them. No, it doesn't work that way. I tell them, you've been trained, you know better than I do, even though you probably don't. Just send it back and let them do the occlusal adjustment. Here are the stages of muscle problems. People clenched and grind their teeth. With sustained muscle contraction, ever do this? Take 2 dumbbells and go like this, say 10-pound dumbbells. For me, it's probably 5. For my wife, it may be 1.5 or 2 pounds. If it's all right, go like pretty soon the muscles start to fatigue. If you don't believe this, take a pen and take a clean white sheet of paper and sign your name right nicely, or you put now is the time for all good men to come to the aid of their country. And write a nice sentence. Then pick up a dumbbell and start doing this, okay? And tell a patient, I want you to, or squeeze a, I usually have a handball, an old handball, and I have them do this. And then pretty soon, I want you to do it 50 times. Oh, I don't know if I could do that. But what happens after about 10 or 15 times, they start to fatigue. Oh, I don't know if I could do this. I'm getting tired. Okay, stop. I'll give you the pen back. Now, write the same sentence on this sheet of paper. And they're holding the pen, and the hand is trembling like this. Look, my hand is just trembling. I can't even hardly hold the pen, much less write. That's exactly what your muscles are doing. When you clench and grind your teeth, they fatigue, they're all pooped out. So when you close, they don't know where to close your teeth together. So you hit here today, you hit here in the afternoon, and later on in the afternoon, you hit someplace else. But you got to stop this clenching and grinding as much as you can. And so now they realize that it is a sustained muscle contraction. Muscles fatigue, and what happens is they lose their muscle memory, okay? And so what we have then is eventually the muscles are going to get sore. And following muscle soreness, they're going to develop. When the muscles get sore, it tells you that they're in the stage called myofascial pain. Now this is the bad boy. And myofascial pain means that this muscle can now refer pain to another site, okay? It's not only the masseter that's sore, it's not only the temporalis. The masseter muscle can refer pain now to the lower molars and the lower premolars. So you can check the tooth, the patient complains of tooth pain, and you take x-rays, the x-rays look good, there's no sensitivity to heat, cold, percussion, and you say, what is this guy talking about? What's he complaining about? It's a referred pain from somewhere else. Guess where it comes from? If the pain from the temporalis is going to refer pain to the upper teeth, the masseter is going to refer pain to the lower teeth. And what's going to happen here is, if you look carefully, the trapezius muscle is going to refer pain up to the masseter region and also to the temporalis region. So very quickly, this whole thing is so simple. People try and make it complex. Okay, you could use all the fancy names you want. But if I took the last 8,000 patients from the pain clinics and we summarized them and looked at the diagnoses, this is what you're going to see. This is what you're going to see. Okay? Now, take a look. So the pain is here, but now it's referring pain to the face. Like this is called referred pain. Now, how can you treat this? Well, how can you diagnose it first? Remember, you have to find out where's the source of the pain and where does the patient say it hurts? Where's the origin of the pain? So you go like this and you palpate this area. Usually, this is going to get sore and that's going to get sore. You say, ooh, right there. Or you go like this and guess what you say? Patient says, always go like this. Patient, you take your finger, not mine, take your finger and point to where it hurts, and they go like this. Okay, right there, anterior temporalis. Okay, now, I'm not going to put my finger on there. I'm going to grab their hand. Okay, and I'm going to press here. And then, how's that? Yeah, that's sore. That's the spot. The pain is not coming from here. The pain is not coming from here. Let me tell you this. Have you ever had a sore on your hand like this? And your wife comes up and says, does it hurt right there? And push, ouch, I just said it was sore. Think about it. It's called the jump response, isn't it? I go like this. If this is the source of the pain, and I do this, ouch, you're going to do this, ouch. If it's here, ouch. Oh, it's called the jump response. You're going to try and get away. But if someone says, yeah, that's the sore spot. It's right there. That's the sore. That's not coming from there. Immediately, I'm going to look for somewhere else. Okay, where am I going to look? What other area is going to refer pain to the face? Look at this. Take out a bottle of ethyl chloride. This is Jack's secret sauce. Okay? What you can do is simply spray, watch the blue line in the middle picture, spray from from the chromium process all the way back like this, up, back, and you're going to spray like this. 3 separate lines. Start down here, about 13, 14 inches away, and just simply spray up 1, 2, 3 like this. Okay. And what you'll find is that the pain in the face, within 10 seconds, pain's gone. Okay? Now the interesting part, the part you came to hear. Okay. What about the patient who comes in and is complaining about, so the pain now diminishes. Now, when we look at pain, we also look at pain in regard to dermatomes. What dermatomes does it cover? Okay. What if a patient comes in and has been clenching their teeth? You ever had this happen? I bet you have. A patient comes in, you give injection, put a clamp on, get the area isolated, get the rubber dam on. All of a sudden, probably 3 minutes in, the patient says, hand comes up, can you stop just a minute? I want to rest my jaw. And you say, of course not, Jack. You were 10 minutes late to begin with. Okay, we're not stopping for you. You're going to put me farther behind. You know you can't say that. So what do? You pull out your bottle of secret sauce. Jack secret sauce, and you go like this. You take the ethyl chloride, and you spray like this. 1, 2, 3 lines. Start in the mid-neck, spray up, but you have to open the mouth, stretch the mouth open first. It's called stretch and spray. You stretch this, you open stretch the muscle, okay? So in the stretch position now, what you're going to do is spray from the neck up. You're going to spray the masseter 3 times, posterior, middle, anterior parts of the masseter like this, and within 3 seconds, 5 seconds, the patient will open from 25 millimeters to 45 millimeters, just like that, okay? So look at the pain. Pain goes down. As the pain goes down, what happens? The patient automatically opens. So perio, we do this in perio all the time. We do this endo all the time. I'll give you some bad news too. And what happens is patients come in, limited opening, even if your friends are doing implants, if you talk to them, for example, if they get a patient coming in, and the guy opens up 25 millimeters, you got to put a first molar or second molar implant in the maxilla or the mandible. And the patient can't open enough, just simply stretch him open, have him stretch open himself, don't pry him open, stretch him open, and then spray 1, 2, 3 on each side of the face. Okay? Now my advice to you is spray this area in the face as well as the area in the back of the neck. I'd spray this first, and then in the back of the neck, and then spray the face. Now what that will do is instantly, within 3 to 5 seconds, bang, this patient's wide open. It's absolutely dynamite. I used to use it for my long procedures in restorative cases. And I recommend it to the dentist. If someone's a little sore, for example, but if they were sore before they came in, my advice to you is to write it down on a RX pad, take some, even though it's over the counter, take this. If you tell them verbally, half the time they won't take it. But if you write it on a script, a prescription pad, give it to them, because what's happening, we usually give it to them right then and there. Okay, so that when you're done with the procedure, the Advil is kicked in or the ibuprofen is already kicked in. Okay? But this is the most important part right here. For endo, you get a wider opening for endo, for perio, for pros, all these things. They're really, really important. Okay?
This is bilaterally.
Bilaterally, right. Oh, the important thing here, I put the black areas, I forgot to tell you. Make sure you protect the ear, and ear canal, and protect the eyes. Make sure you cover the eyes. Your nurse should cover with a Kleenex like this or something here, or a gauze square. And I just simply stuff a cotton roll inside the ear. But I usually kind of bend the tragus forward or back like this to cover the ear canal as I spray like this. And so that's what we do as far as that part is concerned. Okay, so now we want to know, this is the test I told you about early on. when you see a patient come in, for example, and you do the exam, you check the teeth and everything else, one thing you should do is check the vertical opening depending on where the tooth is at, okay? They don't have to open too far if it's an anterior, for example, but if it's a molar or a premolar, you got to open a little bit farther, okay? So you have to know how wide they're going to open. And even if you spray them, how far can they open? If you spray them and they can't open any further, then that's something completely different. Okay, if you spray them, limited opening, stretch them and spray them, and they open another 15 to 20 millimeters, that's muscle. Okay, but if you limited opening and you stretch them and spray them, and they open from 25 to 28 millimeters after 3 sprays on each side, that's a joint problem. They probably have adhesions, fibrous ankylosis, they have other major problems. And that's something you really don't want to get involved in, because if they're having those kind of problems and you get them jacked open, you put this, what's in the reverse clamp, I've seen them. I use them on my specimens to keep them pried open. Okay, watch out for those things. I forgot what they call that little apparatus, but I got a bunch of them in my lab for my cadaver specimen. But if you do that, and afterward now that joint is going to be just hotter than a pistol. Okay, and then now the patient's really mad at you. Okay, so that's the muscle part.
Sir,
yes?
post-operatively, what happens? How's the soreness when you stretch it out like that?
Well, that's why I say give them some Advil or some ibuprofen.
How it takes those?
Yeah, that's all usually it takes. Yeah. You know, this whole thing about the whole pain community is going into narcotics now. You know, we went through that before. I said, gosh, guys, don't you ever read about history? You know, we did this before, and it didn't work. Well, it worked, but what happened, we created a whole bunch of people now that are addicted to these meds, reliant on them. Take a look at the slide on the bottom left-hand side. On the bottom left-hand side is a very interesting slide in that what I'm showing you here this is called the submandibular triangle. The anterior border is going to be the digastric to the hyoid, and the posterior digastric going up to the mastoid process back here. Okay, and this one to the styloid process. Okay, but this triangle in here, this triangle holds the submandibular gland that's back here, and further anterior, the sublingual gland. What's the significance of this? Okay, I'm going to show you well, before I do this, I'll explain this part. It's important, that part is important because if you want to check the joint before you start, you can do it in 15 seconds. Dentists go like this, and you seat the condyle. Remember when you were in school, you would seat the condyle and take a centric record. You would practice at least, okay? So we just gently seat the condyles in the fossa and then have the patient open and close about 10 to 15 millimeters, okay? Let them open and close, but with the condyles seated, okay? Now, what you're doing at that point, you're doing what's called joint loading, okay? Now, the joint can't be loaded halfway down the eminence. It's always going to slide right back into the center of the fossa, okay? So gently seat the condyle, and when you seat the condyle, you know both condyles are seated. Then from there, you can have the patient open and close. Tell them, open please, close, open, close, open, close. How's your joints feel? Good, they're fine. You're cool, that's it, okay? But if you go like this gently and the patient says, ooh, ooh, I said, ooh, what? I said, that hurts. You know, I can feel that in the left side. Wait just a second. You do this again. Oh yeah, when I do this, and then if the patient can repeat that pain, that's not a good sign. Okay, but better they find out at your exam appointment than the treatment appointment, because now you've lost the whole treatment appointment, which is going to be a longer appointment. Okay, but here's another thing. We're going to palpate the muscles, okay? When you palpate muscles, listen to this part. You may palpate the superficial muscles of the scalp, temporalis, and masseter muscle, and deep masseter by pressure. Okay? Any other muscle of the neck, you should not palpate by pressure. You only palpate a muscle if you can hold it within your fingers. Okay? So the sternocleidomastoid muscle, that's a submandibular triangle there. Okay? Another triangle that's important in there is called the carotid triangle. Okay, well, I'm showing you the pressure points, okay? The areas we're going to palpate. So let me show you this. If they say they have pain here, it's probably referred. It probably doesn't originate here. I would say 1 out of 10 times when they say it hurts here, it actually comes from here. So 90% of the time, they don't know what they're talking about. They perceive it, but it's not there. Here's where the pain starts, right about there, okay? The anterior portion there. Here's the deep masseter joint, anterior temporalis, middle temporalis, and posterior temporalis. Okay, on the far right-hand side now, here's a sternocleidomastoid muscle coming down, posterior to the mandible. Look carefully now, because here it is on this lady, and look where the carotid triangle is. That's the carotid triangle. When you take a CPR course, some of you are instructors for CPR courses, okay? What you shouldn't do, especially on older patients, is press in the carotid triangle, okay? You may palpate in the submandibular triangle up like this, but not inward like this in the carotid triangle. And I'll show you why. Okay, so in this area here, so be careful. So we're going to use this area. When you palpate now, look at the slide on the lower left-hand side. When you load the joint, you're going to hold your fingers underneath the mandible. And as you do, you put your little finger in the antegonial notch right here. Oh, you go like this and feel the antegonial notch, okay, underneath. Facial artery comes right across there, okay? So put your ring finger or your little finger there, depending on how big the jaw is. And you seat the condyle up, and then let the patient close, open, close. You tell them, you open, you close, you open. Patient's in complete control. So they're not going to open against resistance, okay, because they're opening it themselves. If you go like this, and you can feel the submandibular gland, the patient's relaxed. You can trust that centric record. If you go like this and you can't feel the submandibular gland, guess why? Why not? The anterior belly of the digastric, when it's contracted, pulls up against the lateral border, inferior border of the mandible. And you can't get your fingers up underneath there. So what you can do is take that spray and simply spray posterior, anterior, and then each side, and then come back again. You go like this. The anterior belly of the digastric, loosey-goosey, you can just feel the submandibular gland really easily. Now take your mandible, you can shake it like this, and take your centric record. Now, let's get back to this slide on the far right-hand side. If you're palpating the carotid triangle, this is what I want you to see. We're dissecting the joint, we're dissecting the masseter temporalis and the muscles of mastication, for example. But that gets kind of boring after a while, so we want to do some other things. And we notice as we're accessing this area, why throw the whole head away by just dissecting the face? We're going to dissect into the neck. And so we've been doing neck dissections for the last 7 years at the same time and collecting specimens, some of these samples. Now, this is where the carotid triangle is, and this is where the bifurcation exists. Now, I'm going to show you this again, the sternocleidomastoid anterior to the SCM and just below the posterior belly of the digastric. Watch me here. I'm going to go like this. I'm going to rotate my head, and I'm going to lean forward slightly. See this? SCM. See this? That's SCM. So rotate and then lean forward slightly. And you can do that very quickly. So if they're laying in the chair, for example, rotate to your side or the other side, but just go like this and just pick it up, and you feel the sternocleidomastoid and palpate up, 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 up. Okay? Now, whatever you don't want, whatever you do, don't do this. Just don't go like this and push in, okay? When you think about this, all the time we've been taking these CPR courses and we palpate, for example, everybody's doing this. Oh, it's right here. Stick it in there. No. Okay, maybe on a young person you might get away with it. Be careful on the old guys, because you're going to release some of the plaque and all the crap that's in that area. Let me show you what's in that area, okay? Let's make an incision through here, okay? And we take this whole thing out, we cut it across, remove it. This is the external carotid, internal carotid. Here's the common carotid coming up. What's this yellow stuff right here? That's what's inside. Look at this. That's plaque. But what happens to the carotid plaque is, what they don't tell you is it calcifies. This stuff is so hard, I couldn't take a number 10 Bard Parker blade and cut it. It was so hard. Finally, when I pressed so hard, I broke a blade first. I did it the second time. By the time it broke the calcific deposit there, it was just about to break the second blade. But this is hard as a rock. It goes crunch, crunch, okay? But what happens is it's this loose plaque. You're able to dislodge some of these pieces, but more this plaque that comes from here. I'm surprised that others haven't reported. We're looking into this right now. When this gets like this, it usually has calcium on the other side. Otherwise, it would perforate through and you get a bleed into the neck, which is not what you probably, we would see. We get autopsy reports on these cadavers that we see. And this is what it looks like. Vigorous palpation may dislodge the plaque. So we've got enough information at this point in time, and we're going to write a few comments in regards to this. Okay, so now let's get back to this one again, and let's look at this right side very quickly. Okay, let's take 1 minute. When someone says, I've had this achy sore jaw ever since I had the new crown made, what does achy sore tell you? Musculoskeletal pain. I've got this throbbing headache when I get sick and throw up. Throbbing is what? It's migraine, isn't it? It's vascular. I get this sharp shooting pain in my tooth. What does it tell you? It's neuritic. Okay? 11 dentists tried to adjust my bite. Oh, right away, the red flags are up too. Okay. So I'm going to not take too much time here. Let's go on, because I can show you better with some slides like this. This is what you should know about joint arthrokinematics, how the jaw works, opens and closes, for example. Many times, I'm showing you these because at first I know that you're an endodontist and you say, well, gee, why is he showing us this? Okay. Because I don't have access to the guys that refer to you. Okay, and they're relying on you. I tell my residents, when you get out, I don't care if you just finished dental school and finished 2 years of endo here at USC, you are the specialist. Everybody's going to look up to you. And they do, okay? You've got to be reliable. If they don't know, someone has to know, okay? Someone has to know. So when you think about this, watch this carefully. So this jaw opens and closes. Look how the disc moves, for example. And at the very end, the patient's going to open. They open 20 to 30, 45. Okay, but 40 to 45 millimeters is about an average mouth opening. Okay, so what's the significance of the picture on the right-hand side? Well, let's look at this. Normal mouth opening is 40 to 45 millimeters. That's equivalent to about 2 fingers like this. If you take 2 fingers and go like this, for me, that's 43 millimeters. Okay, how many in this room were taught you should open 3 fingers? Most of you were taught 3 fingers. Okay, that's totally, completely wrong. You're going to create a hypermobile joint in this patient, in your patients. 2 fingers maximum, because what you've got is you've got to measure the overbite. Let's say a guy opens, just a second, a guy opens 35 millimeters, okay? And you say, oh, but that's short of the 40 to 45. But let's look at his overbite. He's got 8 millimeters of overbite. He has to open 8 millimeters to get to edge. Now he's opening like this. How much farther does he have to open? Probably 33 millimeters. And he's right there. So you've got to add the overbite to the interincisal opening. Okay? So 40 to 45, if a guy has a deep bite, you've got to add that to it. Okay, this has another component to it, another myth, that all clicking is bad. And early on, from 1979, 78, 79 area, things must have slowed down. We had a big rash of people jumping onto the TMJ bandwagon, and they thought the TMJ stood for the money joint. Okay, unfortunately, they found it wasn't. And thankfully, most of them quit. They went back to fixing teeth. Okay, but they used clicking as an excuse. And so they bought instruments like sonograms, sonography, and things like this. When you think about that, all the bells and whistles, we call them modalities, they're not going to do much, especially this sound stuff. All it's going to do is reproduce the sound better. All you need is a stethoscope and probably a 90-cent ruler from Walmart or wherever, from Target. So think about this really carefully. All that the fancy machines do is give you a sharper recording, okay? But they use that to convince the patient that the clicking is bad and they need treatment. They need a $1,000 splint. Okay? Think about this. Let me tell you where 50% of your clicking comes from. You just saw it right here. When a patient opens the mouth, I want all of you to do this. I want you to sit up straight. Okay? And I want you to open your mouth like this. Okay? Easily 35% of you, 40% are going to have clicking sounds from your joint. Okay? Now, if the naysayers are correct, that means you've got a displaced disc, okay? But it's probably that's not the case, because we did this study also. This time I want you to open your mouth, and when you hear the clicking sound, does it click here, here, or here? And the last third. Does it click here, here, or here? If it clicks late on opening, it's the sound of the condyle going over the eminence. It has nothing to do with the disc being displaced. How do you prove that? When you open all the way. Now let's start to close. You start to close, you go click. Now you start to close all the rest of the way. Late opening click, early closing click. Not a disc problem. Okay, that's the sound of you going over the eminence. Big difference. How do you know if the disc is displaced? It could click anywhere on opening. But it's just where it will almost always click on the way back, at the very end, right before you touch your teeth together, it'll go click. So here's what I do. If you're listening with a stethoscope, you can't hear it because what you hear is a teeth touching, clicking at the end, tapping. So you go like this, and you have the patient close, and then touch the teeth gently. No squeeze. Click. That's the disc that's displaced. Okay? So your test as an endodontist as part of your exam, joint loading, and then open please. If any clicking sounds, where does it click? And you mark that on your chart. Okay? Okay, so this is how you could use this basic anatomy of the joint to understand what is going on here. So clicking doesn't mean that the disc is displaced, okay? And, okay, another myth here too is that, I hear people say, see this on the right-hand side? Okay, on the right-hand side, see the slide there? Okay, what happens here is that they say, you don't need a stethoscope. Just put your fingers inside the ear like this, and then as you put your fingers in, have the patient open the mouth. Okay, as you put your fingers in the ear, as they open the mouth, now you hear this, you can feel the clicking sound. And this is more accurate than the stethoscope. I'm sorry, that's totally false. What people don't know is that, I thought I had a picture here. No, I don't. Okay. The lateral, this bone that's separating the ear canal from the joint right here, that's called the tympanic portion of the temporal bone. It only comes out, this is called the tympanic portion of the temporal bone right here. It only comes out halfway behind the condyle. If I took the head and rotated it like this and you look from the back, that bone only comes out halfway behind the condyle like this. So this entire lateral area, lateral portion of the condyle is cartilage, is attached to cartilage. And when you put your fingers into the ear, what are you doing? You're displacing the disc at the lateral pole. Proof? Take your fingers out and repeat this again. All of a sudden, there's no sounds from that joint. So this study has been done numerous times, and so think about this, but no fingers in the ears. And maybe I might think it's kinky and everything, but that's all right. Find something else. Okay. Joint loading, this, I showed you this. This is the bimanual manipulation. You can go through these slides later on to, at your leisure, just copy them off and you can take a look at them. Okay, I'm going to show you about 4 slides quickly about studies that were done by Jeff Okerson. This is a good friend of mine from University of Kentucky, probably the most knowledgeable person in the U.S. If you have a patient with a problem, a joint problem, or undiagnosable problem on the West Coast, send him up to Kentucky. I'm not embarrassed to say it. I refer him patients all the time out there. Okay. What he did was he reviewed this question of the relationship between occlusion and TMD problems. And so this is how he went about it. He looked at the findings from 78 epidemiologic studies that investigated the relationship between occlusal factors and TMD symptoms. He noticed that symptoms were not all the same. Studies were not all, didn't report the same findings. Some found a relationship, some didn't, okay? Some found that occlusion was important, and some didn't, okay? Here's some of the areas that they found that were, all the conditions were not reported in every study, but these are the areas that they studied, okay? So you can take your time and go through this when you print this out later on. It's probably going to be about 20 pages. Okay, so we want to make sure the residents have enough to read at nighttime, and that's you honorary guys. Okay, so that's what you guys do. Okay, what's the relationship now? How common were these things reported? Well, you can take your time and go through these. The 16 studies that showed anterior open bite was related to joint studies, but how many of these were arthritic, and how many of these were just simple disc problems? Okay, how much, what about increased overjet, overbite, and things like this? Let me give you 2 basic rules. Okay, you can have any amount, almost, amount of overbite unless you're going to have the incisors on the lower biting into the palate, incisive papilla. Okay, I don't care if you have 8 to 10 millimeters overbite, but you better give me enough overjet. The deeper the overbite, you must have more overjet, okay? The less the overbite, okay, so that's the main thing here. So we'll take a look at these, take your time and go through these slides, and the final figures are basically this. This is a big, long thing here, but I cut it down. The final figure were 53% said yes, there is a relationship between occlusion and TMDs, and 25 said no. So basically, this is it in a nutshell to me. If you're going to write a paper and you want to prove that that occlusion is a major problem in TMDs, you're going to cite some of the 53. Okay, if you want to say no, then you're probably going to cite some of the others. And basically, this thing is still up in the air. So when you read I know we beat you to death in dental school in regards to reading and everything, reading all the articles, but this is one of my slides I use for my grad students, and Jason remembers this one too. Read not to contradict, nor to believe and take for granted, but to weigh and consider. Good advice. I think this is good advice, Francis Bacon. Okay, so as far as occlusion is concerned, I'm going to give you a whole bunch of these things to look at, some definitions, but I want you to look at number 4 especially. It's called an adaptive centric position. So this is the intercuspal position where the individual has accommodated or shifted the mandible on closure to avoid contact with the malaligned tooth and is comfortable and asymptomatic. Okay, so rather than get into this, we can talk about it. If you're a diehard, you want to go through this, we can, but I want to get to some of the implant material for the endodontist. Is the slide the same as an occlusal interference? Okay. Go through these questions. If the patient is able to adapt and close by moving the mandible to avoid the occlusal prematurity, then there is no interference. Think about that. Okay? If I close my mouth like this and I hit, and let's say if I have a first molar missing, second molar drifts forward and it's hitting, and I close and I'm hitting that last molar, for example, but if I close slightly anterior like this or slightly to the side like this, and I can close, so I don't hit it now, it doesn't interfere with my closure, but now I'm going to close like this. Okay? You say, well, that's impractical. No, it's not. Guess who bites like this? Everyone in this room bites like that. Everyone in this room. I would wager that there's 3 of you in this room that don't have a slide. And you're either someone with a deep bite in the anteriors or a constricted anterior envelope where you can't slide forward. And that in itself is bad. Because if you're your age now, by the time you're 60 to 70 years old, you're probably going to need endo on one of those lower incisors. I can almost guarantee it. Gary's seen it. I saw it on my wife, who needed a root canal endo treatment on lower molar. Have you heard the story about the cobbler's son who has holes in his shoes? That's my wife. Just got pain in my tooth. I said, I got this tooth bothers me. Like, geez. He said, that's sore. Took her down, took an x-ray in the office. And sure enough, he's got a lucency on the end of the root there. And so I got chewed out by my daughter. And okay, and they did the endo on that tooth. Then I took a look at the occlusion, which I hadn't looked at for 10 years or 8 or 9 years. And gee. Anyway, to make a long story short, the pot calling the kettle black, right? Okay. So think about this ability to adapt, okay? And that's all of us. We all have slides. It's not the slide, for goodness sakes, okay? Okay, so the answer to the previous question depends on how far the patient has to move the mandible to fit the teeth together. How far do they have to move to adapt, okay? Is this within the adaptive range for this patient? Is the patient able to adapt to this, tolerate this adaptation, for example? What is the physical and psychological condition of this patient? Believe me, if things aren't going too cool for this person, okay, the slightest high crown, the slightest alteration in the bite is going to drive that. It's just going to add something, fuel to the fire. And this is what we see in pain clinics too. By the way, let me just give you another word of advice quickly here. Because as a caregiver, I see a lot of problems as the disorder progresses. And so keep in mind now that when you see people in pain, that they're probably really normally happy, easygoing, nice people. But when they get pain, they become crabby and things like this, okay? And you may encounter them in a supermarket as a cashier, the crabby cashier. You know, it's not that you're a bad guy. It's something else in their life. It's not, things in their life are not going too well, okay? And I call it, in the pain clinic, explain it like this. It's the pain that's talking. It's the pain that's talking. And so for any of you who have relatives or people that you care for example, or caregivers, and they become you think they're becoming irrational, stop for a moment and think, it's not them really, that person that's talking, it's the pain that's talking, and it's the disease that's talking. So think about this. Okay, so the question really should be, what is causing what's causing the occlusal interference instead of how am I going to treat the occlusal interference? It's critical, therefore, the clinician understand the following terminology. But I'm going to go through this terminology business because I want to get to the next one. I went through this, localized muscle soreness. By the time you get to myofascial pain, this problem can refer pain to other areas, other sites. Okay, I know this guy. Gary, I thank you again. Okay, so the following photograph we took from, we've been doing this study from 2006 all the way through 2015. We're still gathering data from these specimens. We're still doing dissections. What you're seeing now is done on about 283 human fresh cadaver specimens. Fresh cadaver meaning that the body, when the patient dies, they bring him to the morgue and they have the service, and then bring him immediately over to the medical school. And then all the body parts are still there. And then they put him into they test him for all the communicable diseases and so on. And then what they do is they remove the head. I want most of the neck at the same time. So they remove the head, and then we get the head. Sometime it may go into a freezer or something like this in between. But then I get them, I take them to the radiologist. We image them with cone beam. Gary's been really great about this and loaned us his Kodak 9000. And so we were imaging at voxel size 0.040. They changed the software a year and a half into our studies, went to 0.25, 0.20, and Gary's limited field of view imaged a bunch of them for us at 0.076. And amazing what you can see with that machine, just amazing. Okay, we got cone beam images of all these specimens, and then we had a distinct advantage in that we can take them to my lab, and then we can open the joints up that we had already imaged. We could open up the mandible and the maxilla, cut open the sinus. If any lesions or anything there, we could see them. We give some to Gary, whichever ones he wants, and then he does his studies on those too. Okay, so do you recognize these guys on there? Gary, do you recognize that guy right there? Guy, I was in there half an hour last night. My daughter said, "What are you doing in there?" I said, "I don't want a color picture. I want that black and white." Gary goes everywhere. Did you notice that? Here he is. Okay, you're lucky I didn't use the monkeys at the beach like Gary. Okay, so let's take a look at the anatomy. Okay, let's take a look. I made the pictures fairly big, so they'll come up. You can see them because a number of the dissections, this is not something you get to see every day. So I thought I'd make them big for you. Ordinarily, they wouldn't be this big in a normal presentation. But this is the kind of maxilla that we see. If you say, "Wow, they're cadavers, you know, oh, how gross." Not really. Look at this mouth. He needs the scaling, of course. He needs a good prophy. Okay, but if you look at someone like this, a slide like this is typical of what we see. Okay, occasionally we find some trauma patients, but I try not to select those. So what we're going to do is make a cut through here and remove below the orbit of the eye and above the apices of the teeth, and I'm going to cut all the way back with a saw and remove the entire maxilla behind the pterygoid, lateral pterygoid plates. Okay. So what you're seeing here now is you look down into this maxilla. Here's the maxilla on this side, maxilla on the other side, okay? And you notice one side is distinctly different from the maxilla on the sinus, maxillary sinus on the other side. So what I'm going to do is magnify this for you. What you're going to see is something that we're looking for. Usually when they place an implant, for example, they cut a buccal window, a Caldwell Luck. Okay, they cut a buccal window, and then they use a piezo, for example, and then they'll cut the window, they'll raise it up, and then they'll see, because it stops at the sinus membrane, and then they'll push that in carefully, and then they'll feed the grafting material inside. Okay, interesting. But for those who are too cheap to spend the money on a piezo unit, I think it's $15,000, $20,000, but I think it's worth it. I would highly recommend it. Okay, if you're going to do any type of surgery like this. Anyway, what happens is, so you got the maxillary artery comes in the back. Okay, the teeth are up in here. The maxillary artery enters about in here, follows along the buccal wall. This is the maxillary artery coming forward like this. Okay, that's a standard that we think. Okay, the people tell us this is the maxillary artery. As long as it comes in here, enters here, maxillary artery comes in, follows the buccal wall. So this is a little bit of a precaution, but you guys should look for this when you're doing the surgery here. Okay, but we thought, gee, that's funny. What's this dark area down here? That's another branch of the maxillary artery. And it's sitting right on top of the roots that you're operating. Sitting right on top of the roots that you're operating when you're doing the endo on these teeth. If you're using osteotomes and coming up from the bottom, okay, and you're going to come up, if you make a break, for example, if you make a clean break, for example, you piezo and it's clean, and you pop through, but if you break that last floor of the sinus up, and you cut this, you could tear this and cause the bleed inside. Now you got blood all across the floor of the sinus. What about the maxillary septum that's up that you see on the panoramic films? Okay, is that really bone? Not really. What I do with these is I take this maxilla, when I get through, put them in a pressure cooker, and I used to use beetles, but they took so long, I just put them in a pressure cooker. And it takes the tissue right off. Probably within an hour, I've got a nice clean specimen. I can see what's underneath it now. And there's very little bone in that. So I wouldn't count on that. I wouldn't rely on that for help to hold my implants. Here again is another one. It's typical maxillary artery, okay? Typical maxillary artery, but this is farther down. Another branch coming down the floor of the sinus, right down the floor. Again, as I mentioned, couple this with the fact that many of these teeth come right straight through the floor of the sinus. Come right straight through the floor of the sinus, another buccal wall, maxillary artery like this. We've got literally hundreds here. So if there's 283 specimens, and we double that with maxillas on each side, you can imagine. Max sinus on each side. Okay, now take a look at the picture with all the arrows. Okay, these are the roots of the molar. Okay, premolar up in here. Look at these, the tips of the molars. Okay, we cooked all the tissue off. The still part of the maxillary artery that dried up is still in here, along the buccal wall. But now what happens is if someone takes the tooth out, you automatically have a hole in the floor of the sinus. Okay, so now you got to think twice about how we're going to graft. If you're going to graft in that area or not, what are you going to put in there? What precautions do you take? Have you ripped the sinus membrane when you took that tooth out? Let me show you a bunch of these. Okay, here's another from one of our classes. Okay, Gary and Joy helped us bring their X-ray unit over and help us take these X-rays for them. And so here's two implants that the two docs put in at the course, okay, in the area of the lateral, and here's the first bi, okay? And this first bi implant was right up there in the, it was this one here. That's up in the lateral. And this is the premolar right in here. Actually, the premolar was actually sticking up in the sinus, and but they took the tooth out, and then we can see right away there's a big hole up there, still in the bone. Okay, here's that other one I just showed you, and the interesting part here is this. I just put an illustration in here for you, that the greater innervation basically goes to the, you think it goes to the teeth, but it actually, the innervation from these nerves actually go to the interceptal tissues, the PDL, for example. And the PDL also has what we call type 4 mechanoreceptors, which are pressure receptors that sense also whether, how much pressure is being applied, which tooth is contacting first, and things like this. So when you do if you decide to do some occlusal adjustments, do it very judiciously and very carefully. Here's the reason why. If you have a patient say, okay, close, they go chop, chop, it's probably all, the adjustment, if you're really close, it's all over. Why? Because that much pressure, these things have all done what? They've all retreated back up into the socket like this. It's going to take a while before those things finally come back down again. Okay? So when you're doing occlusal adjustment, if you can't finish in 25 to 30 minutes, stop, send the guy home, bring him back in about 4 or 5 days, 8 days. But don't go on and on and on. Beyond, say, 20 to 30 minutes, you're wasting your time. You're wasting the patient's time. You're probably grinding the wrong part. One more thing about occlusal adjustment for you. People take centric records, okay? And then it's the most accurate. Now we're going to mount the cast on an articulator. You want to know what's wrong with that? Do you know how often the initial contact in the mouth, tap, 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 which tooth hits? Oh, this one on the lower right in the back. Tap, tap, okay. Now you mount the cast with a centric record. Guess how frequently the first contact is the same as it was in the mouth? 30% of the time. 70% of the time, you're wrong. Okay, so now you got mounted casts. You're gonna make a grinding chart. Say, I'm going to grind this tooth first, then this tooth, then this tooth. That's a bunch of baloney. You started off in the wrong place to begin with. Okay, but that's another story on how to avoid this. Okay, take a tooth out. Take a tooth out, and what you notice right away is this. We're shining a light through it. So right away, you know that tooth was up in the sinus. That root was up in the sinus. Okay, and look what the sinuses look like. We're not sure. We'd really like to do some studies, but people won't cooperate with us. But smokers like this, we think that it's probably, they're the ones with a real tough sinus membranes like this. And the people who are non-smokers or people who have allergies too will have this real thick kind of sinus membranes. Look at this sinus membrane. Look how thick that one is. Okay, okay, and watch out, for example, if you're doing surgery, a guy has limited opening, and you have to come in slightly from the buccal and use a angle abutment, for example. Be careful of that one. I'll pass this one up. And this was an interesting one here too for us. See this long face, this gadolicofacial? They have a long face, but they also have anatomical variants. What happens in them, because of the narrow arch, they don't have that anterior part of the maxillary sinus. And so the maxillary sinus begins farther back, towards the first molar. And what you and I are going to see then, if you're considering doing implants in these areas, you either have to graft the area or take a look. What happens, the dentist ends up putting the implants in your nose. Okay? Look where the maxillary sinus begins, way back here in the first molar region. What happened to the premolar, way back here, all this stuff in here? What happened to all this stuff that came out here? The dolichofacials, the long-faced people don't have it. And so we've been encouraged to publish this, the incidence of this, but we got a lot of things to do, got bigger fish to fry. Okay, dehiscences and fenestrations. Okay, keep this in mind. Fenestration is from the French fenêtre, la fenêtre, which means the window. Okay, so what you're going to see then is, I'll show you. I'll back up one. Okay, if there's a hole here, that's the window. So this is the fenestration. If this is way up like this, higher than everything else up in here, then that's called a dehiscence. Okay, what's the significance of this? From a clinical standpoint, listen to this. Ever prep 6 anterior teeth or 4 anterior teeth? Okay, you retract the tissue, and then you make some nice tip provisionals and everything else. Take equal care with everything. Get all the cement off. Come back. The patient now comes back like this. Take the provisionals off. Put the crowns in. All of a sudden, 3 of them are perfect, covered by the cervical margin of tissue. The other one, it's up in the air. That was the dehiscence. That was the dehiscence. So do what John Coyce does. Take a perio probe, sound to bone on the labial before you start, before you prep. You better know where you're at. Better know where you start. But there's also good news to this. What can the periodontist do? The periodontist can help the dentist by doing what? Simply going back, releasing at the top, tunneling underneath, and simply pulling that tissue back down and covering the margin. Just simply pulling the curtain back down again. Okay? We used to just hold a thumb on the labial until you form a fibrin blood clot. And then you just send the patient home. And so tissue heals, everything's covered up all over again. But now you have what's called a long junctional epithelium. But they're still holding on. I'm going to go into, not going to say too much about the thickness of the bone, for example, except to show you a couple of things like this. I've got about 4 slides left. Interesting. I want to get back and show you this last part. Oh, here. These now, I told you before, the angled mandible, for example, even in the premolar areas. Here, someone put implants in the molar region. And you can see where the arrows are. This is where the root actually sticks out, the lingual. And these are other dehiscences here. But I want to take you back and show you the last ones here. That's at the very end. That's the fenestration right there. You can take a look at these. Okay, here. Every year I tell the perio residents and endo residents, please, okay, watch out for the lingual artery on that lingual. What happens is the lingual artery comes from the back, forward now, along here like this, and enters right in here, okay? And enters right in here, and enters the bone like this. Okay, if this ridge is resorbed, what the dentist is always going to do is protect the buccal plate of bone. So he's going to go more lingual. And when he does, if he's near the centrals and laterals, he'll go right out the lingual, or he'll bag this artery. But you'll know it very quickly, though, because the blood's going to squirt straight up over your shoulder as everyone is watching. We come back, and the perio residents say, oh, Josephine did it again this week, you know. I said, oh, gee. But you can see what's happening here. Keep in mind the lingual inclination, and here we go. Here we go. This is one of the last 2 slides. Place the implant. You're either going to bag it. That close, you're probably going to bag it. Be careful. Okay, my advice, don't put anything from anywhere where the 2 centrals are. Put them in the lateral central position, but stay away from the central area completely. It's not safe at the midline. And one last comment here basically is this. This is the mylohyoid muscle, and it forms the floor of the mouth. Okay? The importance of knowing this, that this is the mylohyoid muscle in the floor of the mouth, is that if you hit the lingual artery above the mylohyoid, it will bleed up under the tongue, and the tongue will swell up. Or the patient says, no room for my tongue, because it's blood pushing it up. Okay, if it bleeds, if it cuts the artery below this mylohyoid, you won't know it. You usually won't know it unless it's the big one. You cut a big one. And what will happen is it will bleed down into the neck. So you finish the procedure, place your implants, or do your surgery. Patient goes home. What do? You have him take pain meds and get an ice pack, and put it on him like this. And don't move around, don't mow the lawn. And he's going to sit down in this rocking chair at home, and he's going to go like this. And an hour later, he wakes up, and his neck looks like this. He's got a big neck bleed into the neck spaces. Okay, and he's probably having difficulty breathing. Okay, so people have been known to die from this. So be careful, be really careful. Here's the blood vessels. Part of my things, I perfuse the blood vessels, and I perfuse this one on the external carotid on each side, and this is the lingual artery. I perfused it, and that's it. And being a gentleman of frugal means, I decided that I ran out of my expensive perfusion material, and I now use Duralay. It's cheap and it's great, Gary. I want to thank you. I'm done. I want to thank you very much. You've been a kind audience. Thank you, Gary. Good.